Hello, good evening, everyone. Good evening. Let's start with this session of medicine, most important question series. I will be covering cardiovascular system and GIT, and these questions will be the most important questions selected from the frequently asked topic from these two CVS and GIT. Hopefully you have attempted the test paper before. Now we'll discuss these 20 questions of CVS and GIT. So let's start with the question number one. So question is, 70-year-old male with hypertension presents with palpitations and pulse deficit of 20. ECG is shown in the figure. BP is 100 by 70. What is the best next treatment in the management? So in attempting such questions which are clinical plus ECG based, first look at the clinical information. So clinical information is of tachycardia, patient has palpitations, and there is a very important clinical sign which is given, pulse deficit of 20. So pulse deficit of 20 is seen in only one arrhythmia, and that arrhythmia will be atrial fibrillation. So the diagnosis here is atrial fibrillation. Now the ECG. So in this ECG you can see QRS complexes are normal. So it is supraventricular origin, and P wave is absent, and rhythm is irregular heart rate. Irregular heart rate. So these feature will confirm the diagnosis of atrial fibrillation. You can see it is irregular heart rate. Now look at what is the next priority. Is patient stable or unstable? So 100 by 70, patient is stable patient. Patient is stable. So in a patient of stable atrial fibrillation, our first priority will be control the fast ventricle rate with the help of either beta blocker or calcium channel blocker. So here we will go for C option. Yes, all of you have given me the correct answer. It is the C option. Immediate cardioversion will be done if unstable patient. Like patient is collapsed or patient is in shock. Amiodarone is given for monomorphic VTech, and patient is stable. Patient is stable. Warfarin. Warfarin will be needed later on. It will be needed later on, but the first priority here will be rate control. And after the rate control, we will go for the assessment of Charles-Swartz score. If the Charles-Swartz score is coming out to be more than 2, then patient will be started on the warfarin treatment. But that is not a priority now. That is not a priority. Yes. So rate control will diltiazem or beta blocker. Now, moving on to, so before moving on to the question number 2, can anyone tell me what is the Charles-Swartz score in this patient? Can anyone tell me what is the Charles-Swartz score in this patient, assuming that patient does not have any valvular heart disease? So what is the Charles-Swartz score? Will the patient be eligible subsequently for warfarin or NOACs here, anticoagulation here? So tell me what is the Charles-Swartz score for this patient? Yes. So I'm not getting the answer yet. So the answer will be patient is 70-year-old, means more than 65 year. 1 point will be from here, and patient is hypertensive. 1 point will be here. So Charles-Swartz score here will be 2. Yes, it will be 2, age and hypertension. So patient is eligible for anticoagulation therapy. Correct. Yes. So moving on to the next one. Next question, 60-year-old male presents with chest pain for the 2 hours. ECG shows the following findings. troponin is elevated, BP is 80/60. Look at the blood pressure. Blood pressure is low. What should be avoided in this patient? So first let's see which wall MI is this MI. So in this you can see in lead 2, lead 3 and AVF there is ST elevation which is present. ST elevation, yes. So 2, 3 AVF ST elevation means diagnosis here is yes, inferior wall MI. And inferior wall MI is very commonly associated with right ventricle wall MI, because the arteries are same which supply these two. And troponin is elevated, so this is a case of myocardial infarction, clear cut. This is a myocardial infarction, clear cut. BP is 80/60, so here the blood pressure is low. What should be avoided? Can we give aspirin? Yes, aspirin is to be given. Can we go for a emergency PCI in this patient? Yes, we can go for a angiography here. IV fluids and nitrate. So IV fluids, they increase the preload, and they will be needed in cases of right ventricle MI. Yes, they will be given. While nitrate, two things they will do. One, they will further lower down the BP and they will decrease the preload further. So they are contraindicated in RVMI. Contraindicated in RVMI. Yes. Confusion between IV fluids and nitrate. So IV fluids to be given in cases of right side MI. So this is very important to know. Right side MI need IV fluids, so they can be given. So here the answer will be nitrate you should be avoiding. Nitrate you should be avoiding in this patient. And if the option was streptokinase or thrombolytics, so that can also be done if patient is in a non-PCI center. All right. So the second question, important question, is on myocardial infarction diagnosis. Now, coming to the next one. So next is a 65-year-old man with a reduced ejection fraction is on enalapril and furosemide. Which drug should be avoided to reduce the mortality in this patient? So in cases of heart failure with reduced ejection fraction, the drugs which reduces the mortality, these are ACE inhibitor or ARNIs, SGLT2 inhibitor, anti-aldosterone, yes, anti-aldosterone. No, IV fluids which should not be given in anterior wall MI or lateral wall MI, they should not be given. And beta blockers. So these are the agents which reduces the mortality. So out of these, only spironolactone is given here. And one more important point you should note, that SGLT inhibitor are approved now in treatment of heart failure with preserved ejection fraction. So they are now approved for the treatment of heart failure with preserved ejection fraction. So this portion, that is the pharmacology of the heart failure, is very important topic. Usually one question usually come from this section. Now question number 4. Clinical based questions on the cardiac murmurs. So cardiac murmurs, let's understand which cardiac murmur is this and which disease will be this disease. So a young woman has murmur starting with S1 and ending at S2, best heard at the apex and radiating to the axilla. So what is the most likely diagnosis of this condition? So first let's see aortic stenosis. So the aortic stenosis shows this murmur. This is S1, S2, and the murmur will be originating after opening of semilunar valve like this. So this murmur is not starting with the S1, and it will be heard at the right second intercostal space, which is aortic area. While mitral regurgitation is the murmur which is typically pansystolic murmur. It is a pansystolic murmur starting from S1 and ending at S2, and that will be at apex. See, tricuspid regurgitation pansystolic. but it will be at tricuspid area. At the tricuspid area, yes. And mitral stenosis is a mid-diastolic murmur. Mid-diastolic murmur means ki it will be in the diastolic phase, so like this. So this is mid-diastolic murmur at apex. So these are the different types of the murmur which will be present here. So this is heard at the apex, and it is typically radiating to the axilla. So this is nothing but a case of mitral regurgitation. And there is one more murmur which is pansystolic murmur, but it is heard at the tricuspid area. So that is a murmur of ventricle septal defect. Pansystolic murmur at tricuspid area. So these are the three important murmurs, three important condition with the pansystolic murmur. Pansystolic murmur, yes, good. Mitral stenosis is associated with MDM with presystolic accentuation at the apex. So these type of the question, they can give you a diagram based question as well as a theory based question. Now moving on to the question number 5. So question number 5 is, which of the following condition shows a large A wave in JVP? So large A wave in the JVP will be because of right atria is contracting against a resistance. So this is the right atria and this is contracting against some resistance. So when it contract against a resistance, contractions against resistance, A wave will be large. So these condition can be here. It could be a tricuspid stenosis, or it could be a right ventricle hypertrophy, right ventricle failure, or RV compression. If right ventricle is compressed, so RVH can be because of pulmonary stenosis or pulmonary hypertension, and RV compression can be because of tamponade, because of the tamponade. So let's see one by one and know this very important point that the JVP is one of the topic where one question is always and always asked. JVP, and the most common wave abnormality which is asked is the A wave abnormality. So atrial fibrillation will show A wave absent. Complete heart block will show Canon A wave, while tricuspid regurgitation does not affect the A wave because atria is dilated, right atria is dilated. So tricuspid regurgitation characteristically will show X descent being absent. This is a classical finding here. X descent will be absent in tricuspid regurgitation. And pulmonary hypertension will cause RVH, and that will show a large A wave. Large A wave, yes. So the answer here will be D option. D option. Now coming to question number 6, patient has a systolic BP. Let me check who can give me the correct answer here. Patient has a systolic BP of 120 heard in expiration and 100 millimeter of mercury heard in both expiration and inspiration. Which of the following is the most likely finding? So what do you think is this clinical sign known as? Name of this clinical sign. So systolic BP of 120, it is heard in the expiratory phase, and 100 millimeter of BP is heard in both expiration and inspiration. So what is this clinical sign? This clinical sign is nothing but pulsus paradoxus. This is pulsus paradoxus. So pulsus paradoxus, and here the pulsus paradoxus is expiratory BP is 120, inspiratory BP is 100. So this is plus 20. So the most common cardiovascular cause of pulsus paradoxus, most common cardiovascular cause is cardiac tamponade, while most common non-cardiovascular cause will be either COPD or asthma. or asthma. So the answer here is cardiac tamponade. While hypertrophic obstructive cardiomyopathy, it causes a reverse pulsus paradoxus. So it is a reverse pulsus paradoxus. So you should be aware of this important clinical sign, that is pulsus paradoxus. Now moving on to the next one. Next one is again a slightly tricky question. So on the rheumatic fever prophylaxis. So a 14-year-old child presents with migratory polyarthritis and carditis. ASO titer is raised. What is to be given? So let's prove whether it is a case of rheumatic fever or not. Migratory polyarthritis is major criteria and carditis is also major criteria. So here the two major criteria are present. So this is what is needed, minimum needed for the diagnosis of rheumatic fever, and ASO titer is essential criteria. So here essential criteria is also present. So patient will need a secondary prophylaxis. So secondary prophylaxis is needed. And the patient has carditis. So in the carditis, the secondary prophylaxis duration will be, it will be till 10 years or 21 years of age, whichever longer. Yes, whichever longer. So if it is whichever is longer, let's see, patient is 14-year-old. So if we will give till the age of 21 years, it will be 7 years. And if we give it for 10 years, that will be a longer duration. Here the longer duration will be 10 years more from the present age. And by that time, the child will be 24 years of age. So answer is B option. So whichever longer is the B option. Whichever longer is a B option, because if we give till 21 years of age, that will be just 7 years. 7 years. Here we have to give either 21 years or till patient achieve the age of or 10 years, whichever is a longer duration. So this is how the duration is determined, and this is one of the tricky question where mistakes happen. Now question number 8. Question is 50-year-old hypertensive male with CKD, EGFR is less than 60 started on treatment. What is the preferred line of treatment? So in this condition, which treatment will be the first treatment? If with the valvular, how many years? If it is a valvular disease, then it will be ideally lifelong in India. Otherwise, it will be 10 years or 40 years of age, whichever is longer in Western population. But for India, it is the lifelong. It is lifelong. Now, coming to the hypertension with CKD, started on the treatment, which is a preferred agent in this condition. So CKD. Treatment of choice for hypertension is ACE inhibitor. Reason is it decreases the glomerular hypertension. But very important, we have to check serum potassium levels frequently, otherwise it is a very good drug for the CKD patient. And if the option came out to be like ACE inhibitor plus diuretic, then that will be the best option. So if that was written in any of the option, that will be better than ACE inhibitor alone. ACE inhibitor alone. Metalozone only thiazide given in ESRD. Yes, that is ESRD means when the GFR is less than 15. ACE inhibitor is given, but contraindicated if single renal artery stenosis. No, it is contraindicated in bilateral artery stenosis. Now come to question number 9. Question is which lead is placed in the fifth intercostal space at mid clavicular line? So if we will see the side where these leads are placed and the site. So V1, it is placed on the right side. Side is fourth intercostal space, just parasternal margin. V2 is left side and it is same fourth intercostal space, parasternal, while V3 is between V4 and V2 and it is left side, thus it is fifth intercostal space and it is mid clavicular line, while V6 left fifth intercostal space, mid axillary line, that will be placed here. So the answer here will be fifth intercostal space, mid clavicular line. Answer is C option. Answer will be C option. So these questions are very simple question. You should not leave such questions of ECG lead placement. All right, let me check who can give me the diagnosis for this ECG. So 72-year-old patient has bradycardia with ECG shows following finding. What is the diagnosis for this condition? So this is the given ECG, where you can see the QRS complex easily identifiable here. QRS, QRS, QRS. Now look at the P wave. So just before the QRS, this is a P wave, this is a T wave. Again, this is P, P, P and P. So the first question which we will be asking here, what is the QRS? QRS here is a normal width. So unlikely a complete heart block. While is each P for the P wave present? Yes, P wave is present here, but each P not followed by QRS. So the fourth P is not followed by the QRS. So that means it is a type of a second degree AV block. Yes, it is a second degree AV block. Look at the PR interval variability. Is PR interval same or variable? Here this is the PR interval. Then it progressively increasing. Yes. So PR interval, you can check here. The PR interval is progressively increasing. So this is second degree Mobis type 1 block. Mobis type 1 block. In a Mobis type 2 block, PR interval is fixed. PR interval is fixed. While in first degree AV block, each P followed by QRS. Each P will be followed by QRS. Now, come to question number 11. So question number 11 is patient with chest wall trauma present with hypotension, muffled heart sound and distended neck vein. ECG shows electric alternance. What is the immediate treatment? Again, one of the question which will always come in your exam, whether it is a clinical feature, whether it is investigation or management. For this, you should be having all the points clear. So the diagnosis here is it is a case of tamponade. It's a case of tamponade. Most common symptom here is dyspnea. Most common symptom. While the characteristic sign is backstride and Y descent absent in JVP. So it is a backstride, hypotension, muffled heart sound and distended neck veins. ECG will show electric alternance, while specific investigation is echo, which will show right ventricle diastolic collapse. It will show a right ventricle diastolic collapse, and the treatment is emergency pericardiocentesis should be done here. So we will give emergency pericardiocentesis. So this is a case of cardiac tamponade. All right, now come to question number 12. Young athlete collapsed during a practice. Auscultation revealed a systolic murmur, and that increase with the Valsalva maneuver. Likely diagnosis. So this is clear cut. Aortic stenosis decrease with Valsalva. It is an ejection systolic murmur. Mitral valve prolapse. It also increase with Valsalva. HOCM increase with Valsalva. Pulmonary stenosis decrease with Valsalva. So we are left with two options, HOCM or MVP. HOCM or MVP. HOCM is ejection systolic murmur, and MVP is late systolic murmur. Late systolic. So when we are stuck in two option, what will be the most likely answer? So if a young athlete is being given here, young athlete, that will go in favor of HOCM. When it is given as a young female, so then mitral valve prolapse will be the likely answer. And collapse during the practice, more chances of the collapse occur in HOCM, less chances of collapse is in MVP. So these two feature, young athlete and collapse during the practice, goes in favor of HOCM. Again, HOCM diagram based question, histopath about the HOCM, these are all very important topics. Now come to question number 13. Question number 13 is, patient has a wide complex monomorphic ventricle tachycardia. BP is 80/50, altered sensorium. What is the next step in the management? So wide complex monomorphic VTAC is there, and a patient has unstable BP. So patient is unstable. So what will you doing? IV amiodarone is given in stable patients. Adenosine is given in PSVT. It is given in PSVT. So we are left with two options, asynchronized or synchronized cardioversion. So know this point ki asynchronized is given for polymorphic VTAC, or it is given for VFib, VFlutter. While synchronized cardioversion, it is given for monomorphic VTAC or supraventricular arrhythmias like AF or PSVT. So this is a monomorphic. So you will be going for a synchronized cardioversion. All right. So moving on to the next set of the questions. So now I think we have come to the GIT questions. GIT question. In VTech, defibrillation is used. Want answer be asynchronized. Remember, defibrillation is for polymorphic VTechs and ventricular fibrillation. Now, patient has 3 months of watery diarrhea without blood. Stool osmotic gap is less than 50. What is the most likely cause? So whenever stool osmotic gap is given to you and when it is less than 50, so this is a case of a secretory diarrhea. So stool osmotic gap is nothing but a serum osmolarity minus stool osmolarity. So if stool contain more of electrolytes, the gap will be less, while in cases of lactose intolerance, osmotic diarrhea, stool osmotic gap is usually more than 150. Celiac disease and Whipple disease, they are associated with malabsorption, and they will produce fat malabsorption. So they will not be associated with a gap of less than 50. So answer is B option here. Now come to question number 15. So question is, 25-year-old male has a bloody diarrhea, urgency tenesmus for 2 months. Colonoscopy shows a continuous inflammation starting from the rectum. So this topic is highly important. This topic is a topic of inflammatory bowel disease. Now, in cases of which condition continuous inflammation is there and the tenesmus is the key word. So answer is ulcerative colitis. So ulcerative colitis you should diagnose with these features. Tenesmus, it is associated with toxic megacolon, T-ANCA antibody, and very importantly mucosa only is involved. Mucosa only. To make a diagnosis of Crohn's disease, you should have these features. Fistula formation will be there, strictures will be there, ASCA antibody will be present, and there will be skip lesions. And most important point, granulomas. non-caseating granuloma will be present, then you make a diagnosis of the Crohn's disease. In cardiac arrest, resuscitation also with cardioversion will be used in monomorphic VTech. Remember, cardiac arrest nowadays is the term which is mainly due to cardiac asystole, and asystole there is no role of defibrillation. So these will go in favor of Crohn's disease, while amoebic colitis is associated mainly with dysentery and liver abscess. Ischemic colitis is mainly because of the features of blood flow is reduced in ischemic colitis, and patient will have dysentery like features. Blood in the stool will be there, but there will be an infarction or ischemia feature will be present. So the answer is ulcerative colitis. Question number 16. And again, one of the essential topic for all of you is the topic of hepatitis B serology. So let's see, I will start with the options. Resolved past infection. So the status of HBS antigen, anti-HBC and anti-HBS. So let's see. Resolved past infection means the virus is not there. HBS antigen will be negative. It is resolved. Anti-HBC will be of IgG type. And anti-HBS can be positive, can be negative. Now vaccination status. This is negative, and this is positive. A very important table for all of you. Chronic active hepatitis, HBS antigen will be positive, and this will be of IgG type. Always in a chronic infection, anti-HBS will be absent, while in the window period this is negative, and anti-HBC is of IgM variety. Now question for you, what will be the answer of this phase? HBS antigen positive, IgM is there, and anti-HBS is negative. What will be your answer to this serological profile? Last one. Yes, I will be waiting for your answers. So HBS antigen is present, virus is there in the body, IgM is anti-HBC type, anti-HBS antibody is negative. So what will this suggest? Which phase of hepatitis B infection is this? Answer is, it is a acute infection. Yes, this is acute infection. So let's see, surface antigen positive, and anti-HBC is IgG type, and HB antigen is positive. That means virus is replicating. So this is a chronic active hepatitis B infection. So answer is C option here. C option. Yes. Okay, question number 17. So this is one of the very easy question. Obesity, type 2 diabetes, mildly elevated ALT, and ultrasound shows a fatty liver pattern. Viral hepatitis and alcohol use are ruled out. What is the likely diagnosis? So alcoholic hepatitis is ruled out, hepatitis C is ruled out, and patient is obese and type 2 diabetes. So this is the new term for non-alcoholic fatty liver disease, metabolic dysfunction associated steatotic liver disease. So this is the now new name for non-alcoholic fatty liver disease, MASLD. While for the hemochromatosis, you will be given a bronze skin and bronze diabetes. Rather than type 2 diabetes, it will be a bronze diabetes and pseudo gout features. Iron levels will be high, ferritin level will be high. So these will be the features which will be given, and the treatment is, yes, vitamin E we can give in MASLD. Okay, now come to this question number 18. Question number 18 is on the ascitic fluid analysis. So patient has SAAG of more than 1.1. So when the SAG is more than 1.1, that means it is due to high sinusoidal pressures, like causing portal hypertension. Peritoneum carcinomatosis is ruled out, TB peritonitis is ruled out, and pancreatic ascites is ruled out. So even with a single investigation, you can make a diagnosis of cirrhosis, because in all three conditions, SAAG is less than 1.1 in all these three conditions. So therefore the answer will be cirrhosis. Yes, if you do a total protein and it will be less than 2.5, so further favor the cirrhosis, yes. Now moving on to question number 19. Cirrhosis patient with ascites develop fever and altered mental sensorium. Ascitic fluid shows a SAAG of more than 1.1 and neutrophil of 300. Culture is negative. What is the diagnosis? Cirrhosis induced ascites. In the cirrhosis induced ascites, a very important point, neutrophil count will not be high. Neutrophil will be less than 250. Hepatorenal syndrome, bacterial overgrowth syndrome, or spontaneous bacterial peritonitis, SBP, is associated with neutrophil count of more than 250. And very important point, SAAG will be more than equal to 1.1. Know this point. SAG is more than 1.1, but one thing is going here, that is a culture negative. So culture is not so sensitive investigation that it will always be positive. It can be negative. Patient must have taken a prior antibiotics. So that does not rule out. Culture negativity does not rule out SBP. So answer is spontaneous bacterial peritonitis. Now moving on to the last question. Last question is patient has tremors, difficulty speech, personality changes. Patient has mild hepatomegaly. Lab shows a low serum ceruloplasmin and elevated 24-hour urine copper. KF ring are seen on slit lamp examination. So what is the most likely first line treatment for this condition? So patient diagnosis is clear cut. It is a case of a Wilson disease. Most likely it is Wilson disease. And gold standard investigation here will be liver biopsy. So what do you think will you give here? So observation, penicillamine, ursodeoxycholic acid, or prednisolone azathioprine. So the answer here will be penicillin, and it should be added with zinc. Ursodeoxycholic acid is a treatment of primary biliary cholangitis. Prednisolone and azathioprine is the treatment of autoimmune hepatitis. Yes. So that means ki C and D option are given for other chronic liver diseases. So these were the 20 questions. With the help of these 20 questions, I have tried to cover your most important topics of medicine. So with this, we will finish with this special session of MIQ, most important questions. If you have any doubts, you can put in the comment section. Wishing you all the very best for your upcoming exam. Thank you.